focused review, almost like uh, taking a stack of flashcards covering key diseases and drugs
Hmm.
and laying them out for a quick, targeted study session. It's exactly the kind of resource perfect for someone like you, maybe for your audience of medical students on KMR advice.
Yeah, what's really useful here is how practical this source is. It's, designed as a quick reference,
Right.
distilling those essential clinical points in a really structured way.
Hmm.
It's incredibly helpful when you need to consolidate core concepts efficiently.
Definitely. Whether you're reviewing for an exam or, like you said, prepping to explain these topics.
Exactly.
So our mission today is basically to walk through this table systematically, pulling out those crucial bits of knowledge topic by topic, just as they're laid out.
Okay.
We'll hit the core definition, those important signs and symptoms, how these conditions are diagnosed, the common drugs listed right there in the source.
Including the dosages mentioned?
Including the dosages, yeah, and critically, those key patient counseling points. We'll try to keep the pace steady and clear, easy to absorb, like a guided tour through the essentials.
Perfect. Solidifying understanding or preparing content for KMR advice.
Exactly.
Yes, the focus will be squarely on understanding these fundamentals from the source, how symptoms lead to a diagnosis, how the treatments fit,
Right.
and what vital information patients need. Connecting the dots, really, from presentation to patient care, all based on this table.
All right, let's unpack the first topic presented in the source then. Hypertension. When we talk about hypertension, what's the core definition given here?
Okay, so the source defines hypertension as that persistent elevation of arterial blood pressure. Specifically, it notes levels equal to or greater than 140 over 90 millimilli OHG.
That's sustained high pressure.
Exactly. Sustained.
And it points out something really important. It's often asymptomatic. Patients might not even know they have it.
That's a key clinical point, isn't it?
But it can sometimes show up with symptoms like headache or dizziness, the source says.
Right. Diagnosis primarily relies on accurate blood pressure measurement. You often need multiple readings over time to confirm it's persistent.
Makes sense.
And the source also mentions checking lab tests. That helps rule out potential secondary causes, other conditions causing the high BP.
Okay. And for management, what drugs are listed?
The source lists several common classes and examples. You've got amlodipine, a calcium channel blocker, usually 5 to 10 milligrams once daily.
Okay.
Enalapril, an ACE inhibitor at 5 to 20 milligrams once daily. Losartan, an ARB, that's 50 to 100 milligrams once daily.
Right.
And hydrochlorothiazide, a thiazide diuretic, typically 12.5 to 25 milligrams once daily. These are sort of the foundational meds.
Got it. So once diagnosed and treated, what are the essential patient counseling points from the source for someone with hypertension?
Well, the table highlights several critical things.
Yeah.
Strict adherence to meds. Consistency is key for BP control.
Mm-hmm.
Regular monitoring of blood pressure at home is also important. Reducing salt intake, that makes a significant difference.
Big one.
Engaging in regular exercise, another cornerstone. And crucially, reporting any side effects they experience.
Right, because there might be alternatives.
Exactly. It really emphasizes that managing blood pressure is a mix of the medication and those proactive lifestyle choices.
Okay, let's move on to the next condition in the source, often linked to long-standing hypertension. CCF, or heart failure. The source defines this as the heart's inability to pump sufficient blood. What are the telltale signs and symptoms mentioned?
Yeah, when the heart isn't pumping effectively, you start seeing symptoms like dyspnea, that's difficulty breathing.
Especially on exertion.
Right, or when lying flat, that's orthopnea, which the source also lists. Edema or swelling, especially in the legs, and general fatigue are also common signs noted here.
And for diagnosis, how do we confirm heart failure according to this source?
Diagnosis involves putting the clinical picture together with objective tests. So a clinical exam might show fluid overload.
Okay.
An ECG can show rhythm issues or muscle damage. An echocardiogram is vital. It assesses the heart's pumping function directly.
The echo.
Right. And checking blood levels of BNP, that hormone released when the heart is stretched, is a key diagnostic marker mentioned.
And the drugs listed, they seem to target different aspects.
I do. There's furosemide, a Luke diuretic, 20 to 40 milligrams once daily for fluid removal, and enalapril, the ACE inhibitor again, 5 to 20 milligrams once daily to reduce the heart's workload.
We saw that one already.
Yeah, overlaps. Carvedilol, a beta blocker, 6.25 to 25 milligrams twice daily, which improves heart function over time. Spironolactone, 25 to 50 milligrams once daily, another diuretic with hormonal benefits.
Okay.
And digoxin, 0.125 to 0.25 milligrams once recordani, helps the heart pump more strongly and controls rate sometimes.
The counseling points here must be absolutely crucial since CCF is chronic. What does the source highlight?
It emphasizes limiting salt and fluid intake. That's key to prevent fluid buildup, managing the edema and dyspnea.
Makes sense.
Monitoring weight daily is critical. A sudden increase can signal fluid retention needing attention.
It's an important catch.
Reporting any worsening swelling or difficulty breathing is vital. And of course, strict adherence to their prescribed medications. These drugs manage the underlying problem and the symptoms.
Next up, a critical emergency. MI, myocardial infarction, heart attack. The source describes this as death of heart muscle due to ischemia, lack of blood flow. What are the unmistakable acute symptoms listed?
These are the classic warning signs. Severe chest pain, often crushing or tightness, maybe radiating, sweating, nausea, and significant dyspnea are also listed. These scream medical emergency.
Diagnosis in this situation needs to be rapid. What does the source mention?
It relies on the ECG, looking for those specific changes indicating muscle damage, and measuring cardiac enzymes in the blood, especially troponin. Elevated troponin confirms heart muscle injury.
And the drugs? The source splits them into acute and long-term.
Yes, very helpful distinction. Acute immediate management includes aspirin 325 milligrams stat, nitroglycerin 0.4 milligrams sublingually under the tongue for chest pain and vasodilation, and morphine 2 to 4 milligram IV for pain. Then long-term, after the event. Atorvastatin 40 milligrams once daily, that's a statin. Metoprolol 25 to 50 milligrams twice daily beta blocker. Clopidogrel 75 milligrams once daily antiplatelet. And Ramepril 2.5 to 10 milligrams once daily, an ACE inhibitor. These work together to prevent future events.
And what about patient counseling after an MI? Vital for recovery and prevention. What's the advice?
Counseling is pretty comprehensive, educating patients to recognize symptoms of another event so they get help fast.
Crucial.
Taking meds exactly as prescribed, these are preventative. Making those significant lifestyle changes, diet, exercise, smoking cessation.
Big changes.
And participating in cardiac rehabilitation programs. Structured programs help recovery and improve heart health.
Moving on to arrhythmias, abnormal heart rhythms. The source lists symptoms like palpitations,
Feeling the heart race or skip beats.
dizziness and syncope or fainting. How are these diagnosed?
Diagnosis is usually with an ECG to capture the rhythm. But since they can be intermittent, Holter monitoring is listed too. That records the rhythm over 24, maybe 48 hours.
Catches the intermittent ones.
Exactly. The common drugs listed include amiodarone, 200 to 400 milligrams once daily, a potent antiarrhythmic. Metoprolol again, 25 to 100 milligrams once daily.
Beta blocker again.
Diltiazem, a calcium channel blocker, 30 to 60 milligrams 3 times daily. And digoxin, again, 0.125 to 0.25 milligrams once daily. So you see some overlap.
Yeah, definitely. Counseling often involves avoiding triggers. What triggers does the source specifically mention?
It points specifically to avoiding caffeine and alcohol, known stimulants that can sometimes set off arrhythmias. It also stresses taking meds regularly, as scheduled, and reporting any recurrence or change in palpitations.
Shifting gears now from the heart to respiratory. Asthma, chronic airway inflammation, reversible obstruction. What are the classic symptoms listed?
The typical ones noted are wheezing, that high-pitched sound, a persistent cough, breathlessness or shortness of breath, and chest tightness. Symptoms often vary and could flare up.
Diagnosis relies on measuring lung function, correct?
Yes, diagnosis is based on spirometry, measuring how much and how quickly you move air, and peak expiratory flow rate, PEFR.
And the key is reversibility.
Exactly. These tests often show improvement after giving a bronchodilator, showing that reversible obstruction, which is key for asthma diagnosis.
What about the medications listed? Relievers and controllers.
Right. There's salbutamol inhaler, 100 milligrams per puff as needed, PRN. That's the reliever for quick symptom relief.
The blue one, usually.
Often, yes. Then budesonide inhaler, an inhaled corticosteroid, 200 to 400 millisiever twice daily. That's a controller, reducing inflammation. Mosoleucus, 10 milligrams once daily, another type of controller. And ipratropium inhaler, 20 milligram per puff, sometimes used too.
What are the critical counseling points for asthma patients from this source? Inhaler technique always comes up, doesn't it?
Absolutely. The source strongly emphasizes correct inhaler technique. If you don't use it right, the medicine doesn't work well.
That makes sense.
Also avoiding known triggers, allergens, smoke, exercise sometimes, monitoring symptoms, maybe with a peak flow meter. And adherence to controller meds, even when feeling well, is vital to prevent attacks.
Closely related but different. COPD, chronic obstructive pulmonary disease. Progressive, irreversible airflow limitation, the source says. How do symptoms compare to asthma?
The symptoms listed are chronic cough, often with sputum.
Productive cough.
Yes, and persistent dyspnea that tends to worsen over time, especially with exertion. The key difference is that progressive, largely irreversible limitation,
How is COPD diagnosed according to the source?
primarily confirmed by spirometry showing that reduced FEV1-FVC ratio that doesn't significantly improve after a bronchodilator.
Yeah.
That indicates fixed airflow limitation.
Okay. And treatments?
Aim to manage symptoms and slow progression. Tiotropium, 18 millicgrams once daily, long-acting anticholinergic. Salbutamol inhaler, 100 millicgrams as needed rescue inhaler.
Same as asthma rescue.
Yes. Formoterol, 12 millisiever twice daily, long-acting beta agonist. And Bugsnide, 200 to 400 millicgrams twice daily, often in combination inhalers for more severe cases. Again, overlap with asthma drugs, but the approach differs.
Counseling for COPD, there's usually one major point that comes first. What is it?
Smoking cessation, absolutely number one. If the patient smokes, quitting is paramount. Nothing else has as big an impact.
Critical.
Other points include correct inhaler use, getting regular flu vaccinations to prevent infections, and pulmonary rehabilitation programs to improve exercise tolerance and quality of life.
The source includes PFTs, pulmonary function tests, notes NA for definition symptoms because it's a diagnostic tool. What specific tests are listed?
The specific tests listed are spirometry, which we've discussed, PEFR, peak expiratory flow rate, and DLCO measures diffusing capacity, how well oxygen moves into the blood.
And no drugs listed because?
Because it's a test, not a disease treated with drugs. So NA under drugs is correct. Counseling focuses on explaining the test purpose to the patient,
Right.
emphasizing it's effort-dependent, they need to follow instructions and breathe forcefully, and highlighting its role in monitoring chronic lung diseases like asthma and COPD is about understanding the tool.
Moving to endocrinology, diabetes mellitus. Chronic hyperglycemia due to insulin issues, classic symptoms listed.
The classic polys, polyuria, frequent urination, polydipsia, increased thirst. The source also lists unexplained weight loss and fatigue as common signs.
And the diagnosis thresholds given.
Key numbers here. Fasting glucose greater than or equal to 126 milli-GDL, or an HbA1c greater than or equal to 6.5%.
Okay. Common drugs listed reflect different approaches.
Yes. Metformin, often first line, 500 to 2,000 milligrams per day. Insulin, dosage varies hugely, highly individualized. Glympyride, a sulfonylurea, 1 to 4 milligrams once daily, stimulates insulin release. And sitagliptin, a DPP-4 inhibitor, 50 to 100 milligrams once daily.
Counseling is huge for diabetes, requires so much self-management. Key points from the source.
Absolutely critical. Regular monitoring of blood sugars with a glucometer, following a healthy diet and getting regular exercise foundational, learning to recognize and manage both hypoglycemia, low sugar, and hyperglycemia, high sugar, for safety, and performing regular foot care to prevent serious complications. It really underscores that active patient partnership.
Next, thyroid disorders, hyper and hypo. Contrasting symptoms listed.
Quite opposite, yeah. Hypothyroidism, low hormone, think metabolic slowing, fatigue, weight gain, feeling cold.
Sluggish.
Hyperthyroidism, excess hormone, think metabolic acceleration. Weight loss, despite appetite, palpitations, anxiety, heat intolerance.
Diagnosis is via blood tests.
Yes, measuring TSH and the thyroid hormones T3 and T4. Treatments are specific. For hypo, it's levothyroxine, synthetic T4, usually 50 to 150 milligrams once daily.
Hormone replacement.
Exactly. For hyper, it's antithyroid meds like carbamazole, 10 to 40 milligrams once daily, or propylthiouracil, 100 to 300 milligrams per day, which reduce hormone production.
Counseling points seem to revolve around consistency and monitoring.
Yes, consistency is key, especially with levothyroxine, same time daily, often on an empty stomach. Regular labs are needed to monitor levels and adjust doses.
Right.
Patients should report symptom changes and, crucially, avoid abrupt stopping, particularly for hyperthyroidism treatment.
Shifting focus to reproductive health, oral contraceptives, OCs, hormonal pills preventing pregnancy, common side effects listed.
The source lists common, usually mild ones: nausea, breast tenderness, and irregular bleeding, especially initially.
Diagnosis involves history and ruling out pregnancy.
Exactly. Thorough history for contraindications and a pregnancy test before starting. Examples listed include combination pills like ethinylestradiol plus levonorgestrel
Combined ones.
and progestin-only pills like desogestrel.
What are the crucial counseling points for OCs, especially missed pills and risks?
Absolutely vital. Take the pill at the same time daily for best effectiveness. Clear instructions on what to do if a pill is missed. This is critical.
Very important.
And advising patients to report symptoms that could signal rare but serious side effects, like sudden leg pain for DVT or visual changes. Safety first.
HRT, hormone replacement therapy, for menopausal symptoms and osteoporosis prevention. Symptoms HRT addresses.
The source lists classic menopausal symptoms, hot flashes, mood swings. Also notes osteoporosis as estrogen decline affects bone density. Diagnosis is mainly clinical.
Examples of HRT drugs listed.
Conjugated estrogens, 0.625 milligrams once daily. Medroxyprogesterone, 2.5 to 10 milligrams once daily. Often given with estrogen if the woman has a uterus. An estradiol patch is transdermal option.
Counseling involves risks versus benefits. What does the source highlight?
Emphasizes a detailed discussion about individual risk versus benefits. Regular checkups are needed. Reporting any abnormal vaginal bleeding is crucial.
Okay.
And generally, using the shortest duration necessary at the lowest effective dose for severe symptoms. It's a nuanced discussion now.
Moving to specific populations. Pediatrics. Medication management varies by disease, but also by the child. Diagnosis involves.
Weight and age are fundamental in pediatrics. Drug handling changes significantly as kids grow. Clinical exam is also vital.
And the examples show weight-based dosing.
Exactly. Paracetamol at 10 to 15 milligrams per kilograms per dose. Amoxicillin at 20 to 40 milligrams per kilograms per day. Ibuprofen at 5 to 10 milligrams per kilograms per dose. That MGKG calculation is foundational.
Counseling for kids' VIDs is paramount for safety. Key takeaways.
Accurate dosing based on current weight need to recalculate as they grow. Using proper measuring tools like oral syringes, not kitchen spoons.
Very important.
Watching carefully for adverse reactions, and strictly avoiding adult meds unless specifically directed and dosed by a professional.
Another important population, geriatrics. Elderly medication management, common issues listed.
Polypharmacy using multiple meds increases risk of interactions and side effects, increased risk of falls, often linked to meds, and confusion.
Diagnosis involves medication review and checking organ function.
Yes, comprehensive medication review is key, and assessing renal and liver function as decline with age affects drug processing and elimination.
The approach emphasizes dose adjustments.
Exactly. Dose adjustments are often needed due to those age-related physiological changes. Lower doses of antihypertensives or sedatives, for example. The source also lists things like calcium and vitamin D or statins, common in this group, but still needing careful consideration.
What about counseling geriatric patients and caregivers?
Focus on simplifying regimens if possible. Monitoring closely for adverse reactions, symptoms can be nonspecific in the elderly. Regular medication reviews are crucial. And providing support for adherence pill organizers, family help.
Critical area. Drug safety during pregnancy and lactation. Issues listed.
Nausea and vomiting during pregnancy, which might need treatment. And critically, potential fetal effects from medication exposure.
Diagnosis involves confirming pregnancy and getting a detailed medication history.
Yes, pregnancy test and a thorough history of everything being taken prescribed. OTC supplements.
The source gives examples of safe versus unsafe drugs.
Crucial info. Generally safe examples: paracetamol, folic acid essential, iron supplements, samples to avoid due to known fetal risks, ACE inhibitors, warfarin. Big warnings there.
Counseling is about minimizing risk while managing necessary conditions. Core points.
Use only necessary drugs, lowest effective dose. Thoroughly discuss risks versus benefits with a provider for any medication. Actively avoid known teratogens. And always, always consult before starting anything new while pregnant or breastfeeding. It's a careful balance.
Moving to ophthalmology, glaucoma, increased intraocular pressure damaging the optic nerve. Symptoms.
Primarily visual field loss, often gradual and peripheral. Patients might not notice it early on. In acute forms, severe eye pain is listed.
Diagnosis involves tonometry and visual field tests.
Yes, tonometry measures the pressure. Visual field tests assess vision loss and nerve damage.
Common eye drop medications listed.
They aim to lower pressure. Timolol 0.25 to 0.5%, 1 drop twice daily beta blocker. Latanoprost 0.005%, 1 drop at bedtime, prostaglandin analog. Brimonidine 0.1 to 0.2%, twice daily alpha agonist.
Counseling is all about correct use and adherence.
Absolutely crucial. Correct eye drop technique, making sure it gets in the eye. Not missing doses is vital for consistent pressure control. Reporting vision changes or side effects, and regular eye exams are essential.
Another eye condition, conjunctivitis, pink eye, inflammation of the conjunctiva, symptoms listed.
Classic symptoms.
Redness.
A discharge can vary watery, thick, and itching or irritation. Diagnosis is usually clinical exam. Maybe a swab if bacterial infection is suspected.
Common treatments listed.
Depends on cause. For suspected bacterial, antibiotic drops like ciprofloxacin or chloramphenicol. For allergic, antihistamine drops like olopatadine.
Simple counseling points for management and preventing spread.
Practical hygiene advice. Good hand washing paramount. Avoid touching or rubbing eyes. Complete the full course if antibiotics are given. And don't share towels, pillows, etc.
The source also lists essential drugs. NA for definition, symptoms, diagnosis because it's a concept. Examples listed.
Widely used foundational meds. Paracetamol, amoxicillin, ORS, oral rehydration salts, metronidazole, atenolol. Medicines deemed essential for priority health needs.
So the concept is about priority meds. Counseling focuses on purpose and appropriate use.
Exactly. Using them as first line when appropriate. Ensuring availability. Educating on rational use, preventing resistance, misuse.
Finally, the pharmacist's role is highlighted, ensuring rational drug use and patient education, relevant for all prescribed drugs, it says.
Yeah, this section really ties a lot together. It summarizes the pharmacist's critical role. Counseling points cover adherence, right dose, right time, right duration, explaining side effects, advising on relevant lifestyle changes, checking for interactions, drug food, instructing on proper storage, advising on necessary monitoring. It reinforces that vital education and safety role.
Wow, okay. We've just gone systematically, point by point, through this really valuable source table. Definitions, symptoms, diagnosis, the specific drugs and dosages listed, and those crucial patient counseling points for each area. Hopefully, this structured walkthrough, following the source's sequence, helps solidify these core concepts for review, especially for folks preparing for exams or maybe creating content for PMR advice.
What's really interesting, even going topic by topic, is seeing the connections, isn't it? Hypertension links to heart failure, MI. Certain drugs pop up repeatedly. And the core principles, diagnosis, rational drug use, patient counseling, which this table lays out so clearly, they apply across the board. It's a fantastic, concise foundation.
Absolutely. Thinking about how useful this is, especially for medical students, that organized essential review is exactly what you need sometimes to cut through everything and focus on the high-yield points.